COPD, chronic obstructive pulmonary disease. Definition: it's a disease state characterized by presence of airway obstruction due to chronic bronchitis and emphysema. The airflow limitation is usually progressive and not fully reversible. Synonyms: chronic obstructive airway disease and chronic obstructive lung disease. Chronic bronchitis. It's a chronic disease of bronchial tree characterized by cough and expectoration daily for 3 successive months for at least 2 successive years, not attributed to other causes, pulmonary or cardiac. Causes: bronchial irritation due to cigarette smoking, which is the most common cause, more than 90% of the cases, air pollution, car exhaust, industrial pollution, and infections, viral and bacterial, which is an aggravating factor. Pathology: simple chronic bronchitis, hypertrophy of mucous glands, cough with whitish mucoid expectoration, and this is reversible stage. Chronic obstructive bronchitis, organic narrowing and progressive decline in airflow due to mucous gland hypertrophy and infiltration of the walls of the bronchi with inflammatory cells such as neutrophils, CD8 T lymphocytes. Inflammation is followed by scarring and remodeling process which sickens the walls of the bronchi, and that's why this is an irreversible stage. In contrast to bronchial asthma, the cellular infiltration is mainly eosinophils and CD4 T lymphocytes. Emphysema: permanent dilatation and destruction of the lung, distal to terminal bronchioles. Causes: emphysema associated with chronic bronchitis, which is the most common cause. Alpha-1 antitrypsin deficiency due to imbalance between protease, which digest elastin and other structural proteins in the alveolar wall, and antiproteases, which protect against this attack. Compensatory emphysema, such as bronchiectasis and lobectomy. Senile, atrophic emphysema, asymptomatic. Pathology: it's classified according to the site of damage. Centriacinar, pan-acinar, and irregular. Centriacinar concentrated around the respiratory bronchioles. Distal parts of acini are well preserved. It's associated with smoking. Pan-acinar, affecting whole acinus, associated with alpha-1 antitrypsin deficiency. Irregular emphysema, affecting lung parenchyma, patchy, without respect for acinar structure. Pathophysiology: patients with COPD show a combination of emphysema and chronic bronchitis with predominance of certain feature over the other. Type A and Type B. Type A, pink puffer. The patient has dominant emphysema, impaired diffusion, hypoxemia with normal or low level of carbon dioxide. Hypoxemia leads to respiratory stimulation, fighting for oxygen, which will keep oxygen and carbon dioxide near normal levels. So there is severe dyspnea, puffer, and no cyanosis, pink. Type B, blue, bloater. This patient has dominant chronic bronchitis, impaired ventilation, hypoxemia with hypercapnia. The patient is non-fighter for oxygen, so there is no dyspnea, there is cyanosis, and cor pulmonale is common, leading to edema, leading to bloater. If you can't understand anything, we can create a mnemonic. I didn't create this. Dr. Mowafy created it. Type B, bronchitis is dominant, bloater, blue. Type 2, there are 2 things, hypoxia and hypercapnia. While type A, type 1, 1 thing, hypoxia without hypercapnia, and emphysema is the predominant. If we're going to compare between type A and type B, remember type A is a pink puffer, so severe dyspnea with pursed lip breathing, while in type B, mild dyspnea. In type A, small sputum volume, while in type B, large sputum volume. Type A, thin patient. Type B, obese. Type A, no cyanosis, no edema, while in type B, cyanosis and edema. Investigations: in type A, near normal blood gases, radiological evidence of emphysema and impaired transfer factor, while in type B, abnormal blood gases, no radiological evidence of emphysema and no reduction in transfer factor. Clinical picture: symptoms: history of heavy smoking for many years, cough present when waking up first, then throughout the day, productive cough, initially mucoid, then purulent sputum with exacerbation of the disease, worsens in winter, and after chest infection, regarded by the patient as an expected consequence of smoking, daily sputum for 3 or more months in 2 successive years, define chronic bronchitis. Dyspnea, slowly progressive over the years and commonly the reason why patients seek medical attention. Wheezes, they are persistent and continuous, unlike in bronchial asthma. Weight loss and anorexia in severe COPD. Signs, general. No signs in mild cases. Tachypnea, tachycardia, pulsus paradoxicus, puffy eyelid, congested neck vein, prominent accessory respiratory muscles in the neck, inspiratory tracheal tug due to contraction of the low flat diaphragm, elevated shoulders with professional attitude, enlarged liver, lower limb edema, abdominal protuberance due to low position of diaphragm with displacement of the abdominal contents. Clubbing is not a feature of COPD because it suggests malignancy and bronchiectasis. Local signs: inspection and palpation, increased anteroposterior diameter of the chest, barrel-shaped chest, diminished chest expansion, and lower intercostals in drawing with inspiration. Percussion, hyperresonance with loss of normal cardiac and liver dullness, auscultation, prolonged expiration, rhonchi throughout the chest, and basal crepitations. Complications. For the lung, we have bronchiectasis, pneumothorax, respiratory failure, and recurrent chest infections. Heart, right-sided heart failure, cor pulmonale, left-sided heart failure, and myocardial hypoxia can increase the risk of ischemic heart diseases. Renal, salt and water retention due to renal hypoxia, proteinuria due to renal congestion. Stomach, peptic ulcer, complications of chronic cough, ruptured bully, hernia, and insomnia. Investigations, radiology, chest x-ray may be normal. Specific findings: it may be normal in early stages, but we may find hypertranslucency of the lungs with transverse ribs and wide intercostal spaces, low flat diaphragm, narrow elongated cardiac shadow, ribbon-shaped heart, emphysematous bully, increased bronchovascular marking, radiological signs of complications such as pneumonia and bronchiectasis. CT chest, diagnose early cases. Pulmonary function tests. Spirometry, we have decreased forced expiratory volume 1, it's less than 80%, decreased forced expiratory volume 1 over forced volume capacity ratio, less than 70%. FEV1 depends on the disease stage. So we have stages for COPD 0, 1, 2, 3, 4. FEV1 or forced expiratory volume 1. For stage 0 at risk, it's more than 80%. Stage 1 mild, more than 80%. Stage 2 moderate, from 50 to 80. Stage 3 severe, from 30 to 50. And stage 4 very severe, less than 30. FEV1 over FVC ratio is normal in stage 0 and less than 70% in the other stages 1, 2, 3, 4. Bronchodilator test usually improves FEV1 but by less than 15%. Unlike bronchial asthma, the response would be more than 15%. Recently, inspiratory capacity is suggested to be more sensitive than FEV1 as it correlates better with air trapping. Gas transfer coefficient of carbon monoxide is low in severe cases. ECG, P pulmonale and RVE in cor pulmonale. Blood changes, hypoxemia with normal or low level of carbon dioxide in type A, hypoxemia and hypercapnia in type B, secondary polythysemia due to chronic hypoxia, and maybe deficiency in alpha-1 antitrypsin. Normally it's from 2 to 4 grams per liter. Estimation of serum alpha-1 antitrypsin indicated in any young patient less than 40 years with emphysema. Echocardiography to assess cardiac function. Differential diagnosis. We have bronchial asthma, congestive heart failure, bronchiectasis, and TB. Bronchiectasis differs than COPD by having large volumes of purulent sputum, clubbing of fingers, coarse crepitations, and chest X-ray or CT will show bronchial dilatation. Congestive heart failure differs by having fine basal crepitation on auscultation, dilated heart and pulmonary edema in chest X-ray, and in pulmonary function test, there would be volume restriction, not airflow limitation. Bronchial asthma differs from COPD by having reversible airflow limitation, early onset in life, family history, symptoms at night and early morning, allergy, rhinitis, or eczema, and the bronchial dilator test would improve the FEV1 by more than 15%. So if we're going to compare between COPD and bronchial asthma, smoking history is positive in COPD and negative in bronchial asthma. The course of the disease is progressive in COPD while intermittent in bronchial asthma. Cough in COPD in early morning, while in night and early morning in bronchial asthma. Purulent sputum in COPD and not purulent in bronchial asthma. Dyspnea all time in COPD while only in attacks in bronchial asthma. Central cyanosis may be present in COPD with generalized wheezing all the time, while in bronchial asthma there is absent central cyanosis. It may be present in acute severe asthma, and we have generalized wheezing in attacks. Peripheral edema may be present in COPD while it's not a feature in bronchial asthma. Spirometry, decreased FEV1 is always during COPD while it's during attacks only in bronchial asthma. Bronchodilator test, we've talked about it. Response to cortisone is poor in COPD and good in bronchial asthma. Treatment is divided into prevention, drug therapy, non-pharmacological therapy, and treatment of acute exacerbation. Prevention, smoking cessation is vital in late stage of the disease with influenza and pneumococcal vaccination. Drug therapy, we have bronchodilators, cyphilin, corticosteroids, antibiotics, and alpha-1 antitrypsin replacement. Alpha-1 antitrypsin replacement monthly infusion is indicated in a patient with serum level less than 310 mg per liter and abnormal lung function. Antibiotics should always be given in acute exacerbation. Amoxicillin and erythromycin may be given, but new generation fluoroquinolones such as levofloxacin and macrolides such as azithromycin can be more effective. Corticosteroids less benefit in COPD than in asthma. It's used in acute exacerbation of COPD or in patients with overlap with asthma, asthmatic bronchitis. Thiophelin can be given. Bronchodilators, we have short-acting and long-acting. Short-acting SABA, short-acting beta-2 agonists, salbutamol. Short-acting anticholinergic agents, ipratropium bromide. Long-acting bronchodilators, long-acting beta-2 agonists, salmeterol, given twice daily by inhalation. And long-acting anticholinergic agents, tiotropium bromide, it's given once daily. Non-pharmacological therapy, rehabilitation, exercise, and diet, both over and underweight can be a problem to COPD patients. Long-term oxygen therapy, one of the principal non-pharmacological treatment for patients with stage 3 and 4. Oxygen via nasal cannula is given to raise oxygen pressure to 60 mm mercury for at least 15 hours per day. Long-term oxygen therapy to increase survival, exercise capacity, lung mechanics, and mental state, and to decrease pulmonary arterial pressure. Surgical treatment, lung reduction therapy, lung transplantation and bulectomy, removing of non-functioning large bulla to decompress the rest of the lung parenchyma. Treatment according to staging. Stage 0, avoid risk factors and influenza vaccine. Stage 1, short-acting bronchodilator when needed. Stage 2, regular treatment with one or more long-acting bronchodilators. Stage 3, inhaled corticosteroids if repeated exacerbation. Stage 4, long-term oxygen therapy, considers surgical treatment. Treatment of acute exacerbation. Short course steroids, oxygen therapy, mechanical ventilation may be considered in some cases, non-invasive positive pressure ventilation, bronchodilators, nebulized or inhaled, and antibiotics if two of the following are present: increased breathlessness, increased sputum volume, or increased purulence of the sputum. Indications of ICU admission and mechanical ventilation of COPD patients: severe dyspnea, responding inadequately to initial therapy, severe acidosis, confusion, coma, persistent hypoxemia if oxygen pressure is less than 50 mm mercury, or persistent hypercapnia if carbon dioxide pressure is more than 60 millimeter mercury. And this concludes our chapter for today.